this week on the BackTable podcast.
So we want to be 100% certain that we are doing the optimal ablation zone, because a too big ablation zone is not good either, right? That we're getting the optimal ablation zone. And hey, could we reshape the ablation zone as we're working? Is it possible to have the same probe do something spherical versus something different based on what we need, right? Wouldn't that be cool? Is it possible, again, to, whether it's through AI, through some of this linkage between maybe perhaps the CT system, the ultrasound, the machine itself, the ablation machine, and to be very confident, right? Like to be able to come out and tell the patient that we're not just sort of confident with our technical success, that, down the road, hopefully with more data, more research studies, and maybe AI or other fusion, software that we yes, are technically very happy, but now we have more robust data and experience to say that we're even more confident than we were, again, 5-10 years ago, that now our chances for clinical improvement, right, are even better.
We know that in interventional oncology, the ablation workflow can often feel like a stop-and-go process with varying therapies and disconnected systems. Every minute spent navigating complexity is a minute of focus diverted from the patient. That's why Varian, a Siemens Healthineers company, engineered the IntelliBlate microwave ablation system through a deep partnership with clinicians. IntelliBlate's innovation lies in its next-generation intuitive system design and the capability for highly controlled precision ablations. Take, for example, the Z-Mitri probes, which are designed for large, controlled spherical ablation zones, and include a novel feature, 3 thermocouples that provide continuous temperature monitoring inside and outside the ablation zone. Complementing the Siemens Healthineers suite of imaging and software solutions for ablation, IntelliBlate is the future-focused microwave ablation platform. Learn more about IntelliBlate by visiting www.varian.com/IntelliBlate or contact your local authorized Varian field representative.
I'm Sabeen as your host today, and I'm really happy to welcome back Dr. Jason Hoffman, interventional radiologist from NYU. Welcome, Jason.
Thanks so much. It's great to be back. Good to see you.
Thank you. Good to have you. I mean, again, we were just talking about your portal vein thrombosis episode that you experienced yourself, and you're still alive, thank God, so we can pick your brain some more.
Absolutely. Thrilled to be here for many reasons, including that, yes, I'm a very satisfied interventional radiology customer and patient as well, for sure.
Amazing.
For sure.
Amazing. So, today we're going to be talking about thermal ablation of metastatic liver lesions. And I'm pretty excited to be the host, actually, because, I'm a disciple of Riyadh Salem, right? So I'm a Y90, Y naught kind of guy. And it's funny, I would always find a reason to do Y90 over other modalities until more recently when I did a little microwave and I was like, oh, this is really good, right? And so I kind of want to really pick your brain in this episode. And I know there's a lot of people in the audience that are like me too, that are like, they'd rather do Y90, whether it's due to the, so many reasons. So I kind of want to open up the floor and see and kind of have you convince me and everyone else like why, ablation is better.
Understood. Right? Yeah. So look, I think first of all, in general, right, from an educational philosophy, we sort of know what we know, right? And we tend to focus on things that we learn in training, rightfully so, or respectfully so, appropriately so. So many awesome, really genuinely awesome training programs around the country. But things evolve, and there's also different options out there that sometimes you're just not exposed to, right? And for me, when I was trained as a fellow, I did my fellowship 2009 to 2010, so it's been a few years ago now, and things have evolved tremendously in the interventional oncology space since then. But I had a bit of a mixed experience. Certainly, ablation, embolization, Y90 has evolved tremendously since then, of course, and Y90 is great. Then again, I think ablation is also great, and the collision trial is probably the biggest sort of ablation trial people talk about most recently in terms of metastatic disease. But I think, again, it's all about using our expertise, using our knowledge, using our skill set, staying open to learning about new technology in a data-driven, focused, sort of patient-centered way, and then figuring out, look, it's not a one-size-fits-all approach, right? I mean, there's some people that will be very, very, very ablation heavy. There'll be some people I realize that will try to do Y90 for whatever it may be, including, radiation segmentectomy, super selective, and that's awesome. But I think there's probably room for decision-making, for being able to incorporate certainly ablation into many people's practices. technology's changed tremendously. I think, when I was a trainee, we learned about radiofrequency ablation, right? I mean, certainly cryoablations existed, but out of all the ablation tools, I think microwave really has transformed tremendously, right? The old school concern was, tail burn or you're not being able to control, not having a predictable zone of ablation, very sort of elliptical, not spherical. And I think that's also evolved a lot in particularly the last 5 years, 10 years.
Perfect. Yeah. Exactly. We're going to get into that. Just before we started recording too, we were kind of talking about a little bit of your background. I mentioned your NYU, but I didn't realize there's, different sections of NYU. So like how does that work? And how did you get interested in liver-directed therapy in your section?
Sure. So I work at a hospital now. It's called NYU Langone Hospital, Long Island. So it's in Mineola, about 20 miles east of Manhattan. And that hospital used to be called Winthrop University Hospital. It merged into the NYU system about probably 7-8 years ago at this point. But I've worked there for about 15 years, so I've sort of grown through a lot of practice evolution as well in terms of how the enterprise works. But when I came from Penn and moved back home to New York, I'm from Long Island, I was brought back. One of my jobs was to try to grow an interventional oncology practice. And those first few years, it was a struggle in a way,
Sure.
right? You can be the best, whatever it is, interventional radiologist or anything else in the world. You hang up your shingle and that's what it is. It's a sign, right? You have to, prove yourself, show your worth, be at tumor board, make sure that people understand sort of the value that you bring, that you're there to collaborate, know the data, how to talk. That being said, sometimes you have trouble growing practices. So for me, having a really great interventional oncology, I think training when I was at Penn, I felt ready to hit the ground running, but I still had to find my way. So I'll never forget, Mike Sulin came out my first year. We brought him out as a visiting professor, and he said that to me, like, Jason, he's like, look, I can come out here and you could argue that I'm, one of the more well-known interventional radiologist, interventional oncologist. He's done tremendous research, great teacher. And I still have to show people, right? I have to show people my value. What I've done before only counts so much. So I took that, I think I worked really hard. We have a much larger, more robust group now than we had years ago. There's 7 interventional radiologists now on the Long Island campus. We have more than that, probably a little more than double that on the Manhattan campus. And I think as a whole, we have solid expertise. And the bottom line is we can help a lot of patients. So, we're a separate section, long-winded answer, than the Manhattan section, but we collaborate. We all know each other, obviously, and sharing resources, sharing experience, occasionally getting together at meetings or meeting up, things like that is great. We joked earlier that, for me, 20 miles from where I live to Manhattan feels like a world away. It's much more than 20 minutes. It could be hours. Any city has that sort of downside. So we don't see each other as much as we'd like, probably across the campuses, but, we do the best we can.
And it seems like part of the NYU system, you're maybe a little bit smaller of the hospital. And when you started too, I was also in charge of trying to start the IO program. Did you have access to all the tools? There's a lot of stuff out there, and more stuff that's but did you have access to, glass, resin, cryo, RFA, everything?
Yeah, it's a great question. So again, this is going back 15 years, well before the merger. But when I first got there, there had been one of my mentors from when I was in training was there. So it's not like there weren't good people there back then, but the infrastructure, the more people, more, I think, better trained IRs in terms of coming up newer practice were there now. We had, resin at the time. There was, we can do ablation. We'd often bring a vendor in as needed. That's evolved, tremendously. Now we're many thousands of interventional oncology cases in over 15 years. However, when we merge into the NYU system, of course, that brings us even more integration, more opportunities for collaboration. My system, NYU Langone Health, they're growing tremendously, right? What system, I guess, isn't these days, but there's more providers, right? More referrers, the hepatology service, the transplant service, surgical oncology service, MedOnc, everything is more robust now on Long Island than it was 15 years ago. And they were great people there 15 years back, but the system has evolved tremendously. So there's no shortage of patients, which is a good and bad thing, right? We see a lot of suffering every day of patients with lots of different diagnoses. We've talked about my experience, obviously, on this podcast years ago. But with that is opportunity, right? Hopefully opportunity to use our tools well, whether we have a little bias, shall we say, to Y90 or to ablation, sure, to whatever it may be, yep, use that as a healthy bias, but keep our minds open to say, okay, what's best for this patient? Even though it might not be my go-to thing in the average patient, how can I best sort of serve and help this patient?
Totally. Bias is real, right? Education bias is real. That's what I was telling from the very beginning for me, but it's something that I think is important, and I didn't kind of really click for me until a couple of years into practice is that this episode, we're going to be talking about Mets. Mets are very different than, primary liver cancer, right? It's very, very different than ACC. So, what makes metastases different, and how does that affect your decision tree on liver-directed therapy?
Yeah, a few things. I mean, the generally speaking, right, the environment itself, right, the liver itself is a bit different. Of course, it's still a liver, but cirrhosis versus not, fibrosis, portal hypertension, various things that we may or may not see. Many patients with metastatic disease end up eventually with multiple sites of disease. And while I think we are better and more experienced and more knowledgeable with super selective embolization and super selective Y90, there's actually, again, substantial data and experience over the years about ablation, particularly in smaller lesions. And now in the collision trials, again, a more recent example of a strong study, right? A well-designed study really showing advantages, efficacy, safety, and good, survival outcomes, prognosis, comparing patients with, metastatic disease. It can be up to 10 lesions, right? Multiple lesions potentially, typically smaller lesions, right? Usually 3 centimeters or less, showing really basically equivalent options, shall we say, almost to surgery and survival. And, again, might be some different concepts with comparing to patients with HCC and cirrhosis. Now, this may evolve, right? We know our colleagues that might be more Y90 focused. Certainly there's more studies that are going to be done and we'll learn more. I do worry sometimes, if I have a small lesion, 2-3 centimeter lesion, if I think I can ablate it, great. And absolutely, I could probably also do a super selective radioembolization. I do sometimes worry about potential sort of toxicity or side effects of that. I worry about maybe sometimes saving that for down the road if I might need it for more extensive disease, whether it's even if it's salvage at that point. While it's rare, I've definitely seen over the years from colleagues or peers right around the country that sometimes you see a complex sort of complication, difficult outcome. Maybe it relates to using particularly high doses in a targeted way, sort of maybe not. But even if you do segmentectomy, you're still treating a larger part of the liver parenchyma than typically if you're going to be doing ablation. And for me, that's an important thing. I think my patients are tolerating ablation well. I mean, it's one procedure. Again, I think the ablation technology, again, in particular microwave, I think it's a much more powerful and reliable option than it once was. And for me, I mean, that's a really nice opportunity, a nice advantage we have to be able to offer this to patients.
Totally. I mean, yeah, same when I came out, right? RFA was just kind of going down. I mean, is microwave your go-to? I mean, is there any RFA that you're doing? Is there any cryo that you're doing in the liver?
No, I mean, in the liver, I know we're really focusing on the liver. Really, microwave is my go-to. I mean, occasionally a cryo case, but really microwave is my go-to. And I know that, there's a couple options out there and one could argue those sorts of things, and that's great. I historically, when I built up my renal ablation practice, which I know has nothing to do with today,
that's
other
right,
than part of the reason is I did a lot of cryo in the kidney. I would sometimes do microwave, and as new technologies came out, if I was happy with a particular vendor, and then I typically would talk to them about whatever device they may have. And that's actually how I came to using what I'm using now for microwave is more of a relationship from a customer service perspective, honestly, more than anything. And that led me to use what I'm using now. And I've been super happy with it. And again, I really do, my experience has been that, again, the microwave now, again, more powerful per probe, more durable, more sort of reliable. I think there's more real-time sort of feedback we can get now than we would have had years ago. So all those things I think are nice pluses, shall we say, in favor of where we are with microwave.
Yeah, totally. I mean, and how fast it can be, right? So it's so nice. So going back to Mets, right? What are like the common Mets that you treat or have treated, and what are the do you treat any Met under the sun? Or obviously after a multidisciplinary discussion, and we're talking about liver-directed therapy patients, or is there any Mets that you don't like to treat with the thermal ablation?
So I think that it would be an overstatement to say to treat anything under the sun, right? We got to, like you said, it's all in the context of a multidisciplinary discussion, optimally tumor board. Sometimes I realize on the tumor board meet, you might have some outside conversations with the oncologist or any other people involved. By far for me, colorectal Mets would be really the most common. As much as I realize one can treat a potentially large number of Mets, 5, 6, 7 Mets, I tend to not do that. I'm looking for patients who have, 1 or 2 lesions. I think for me, tumor biology is important. That can be hard to figure out at some time, right? But if you have a patient who has rapidly evolving, rapidly progressing disease, one has to really set expectations well, not just with the patient, but with our oncology team, just to make sure we really think we're doing the right thing. Hopefully down the road, we'll get down the path of ablating part of a lesion or a full lesion when there's metastatic disease, or chasing the famous abscopal effect.
Yeah.
I think that's relatively rare these days. We have not found the holy grail. I hope over the coming years, we'll have more direction of how to utilize our tools along with immunotherapy and things like that. But for me, a conversation with the oncology team obviously is really important. And as much as we need to advocate and be experts in what we're doing, I think the collaboration is definitely important, because unfortunately, many patients with metastatic disease, even if we do a great ablation and we control that disease, may end up eventually having disease elsewhere. And if they have more disease in the liver, okay, let's take a look. Let's look at their liver function. Let's look at their performance status. Let's look at their, where they are in their treatment, where the lesion is, and figure out whether more ablation or something else makes sense. But to have appropriate ownership of that patient longitudinally, clinic and a tumor board, while still, I think, respecting obviously the important role that our colleagues, if we think about pillars of IO, right? If we think about RadOnc and MedOnc and us and SurgOnc, some people don't want to put us in that on a pillar,
Sure.
but I think we belong there. You just have to be, I think, really thoughtful and careful. If there's sort of a unique, uncommon met that's in the liver, but it's a solitary met or a couple of small lesions in an area that I think is safe, absolutely, I want to be involved in that discussion, and I want to educate that patient and potentially that oncologist about what I think I can offer. And often it is ablation. And if it's something else, okay, but let's make sure that we're doing our number one due diligence for our patient, but then also, to support the overall program.
Totally. I mean, you brought up one thing, and I had a lot of trouble with this, and this might be a little off topic, but in tumor board, there's a couple oligomets to the liver, newly diagnosed of colorectal. And a lot of times they'd be very easy to treat, liver-directed therapy, PERC microwave, and I would offer that. But then the question would be like, okay, well, maybe there's micrometastases other places. Let's do chemotherapy first for 3 months and see how things progress, and then readdress. And I felt uneasy and unsettled, because I was like, okay, I could just treat these lesions, and then that's my radiologist, right? I see these images, let me treat these and then do your chemo. But how do you address that, and what do your oncologists do?
Yeah, it tends to be sometimes hard to predict some of these conversations, even though we're trying to be data-driven and really robust and multidisciplinary discussions. But I think in our practice, we've worked really hard over the years to again, demonstrate our value, mixed of, number one, our oncologic value for our patient, but our value at the tumor board. And then also, again, helping to have ownership over that patient, right? We're not just going to do an ablation or do whatever it is that we're doing and disappear and not be reachable, that we really are there, good or bad, right? Most of our outcomes are good. It's rare to have a complication, of course, but they happen. And look, occasionally, despite a really good procedure, whatever it may be, sometimes we just don't get the response that we expect or we want or we hope. So, and again, at a tumor board, for example, if it doesn't go maybe quite how I was hoping or as I wanted to hope, sometimes afterwards I'll take it offline, and I'll call that oncologist, I'll call the surgeon. And it's not that I'm trying to sell anything, right? Because you want to be careful that any procedure you do in IR, you're not there to sell it to the patient. I mean, sometimes we feel like we are a little bit, right? Or to our referrer, but you're there to educate the patient, and you're there to educate the referrer. And, you're there to then hopefully support that patient in a decision that is the best for them. I don't know if I've said this before in one of the podcasts, like this is one of my soapboxes, but the word doctor in sort of Latin origin is basically is teacher. So part of what we are there to do, and that's to me a huge role of clinic, is to obviously evaluate the patient, sure, make sure this is the right thing, but educate them. And I think as a whole, our specialty, we do a really good job at that. We always want to strive to do better, but many times we do better than our peers because of how we've built our clinic, and we have the time and the infrastructure to really spend a few minutes, or sometimes much longer than a few minutes, to educate. So again, sometimes I'll reach out, a long-winded answer I realize, but sometimes I'll reach back out to that referrer and just try to have a conversation and say, look, I understand that you've decided to go with systemic therapy. I'm happy to follow along if you'd like me to see the patient now. And I understand that, and perhaps the decision isn't to ablate right away, but I'm happy to see the patient, do a consultation, set the stage, explain some options, and if we need to sort of pull the trigger, we're ready to go, and we'll get things taken care of efficiently. That has helped over time. I think when I first got there, again, no disrespect to my colleagues that were there with me when I got there, but we were building a clinical program, right? So it took some time for people to see that, but I think my current colleagues that have joined the practice now over the years are the same way. And I think we're bought in to work really hard to do the right thing for the patient. And if a few times we think we're the right thing and it doesn't happen, we're not going to get frustrated. We're going to just focus even more and just try to, again, if you're doing the right thing, right? If you're advocating for the right thing, maybe it sounds a little naive, but I think generally speaking, that's going to get us to the right place, and it's going to keep us out of going to the wrong place professionally or personally, right?
Totally. It's funny, the amount of patients that have told me, like, oh, like you actually like explain the procedure, you're like teaching. You're right. I think maybe I never thought about it that way, that it's like the way how we kind of built our specialty in our clinic and the way is different than maybe some other specialties out there treating the same disease processes, right?
Yeah, I mean, look, we all get frustrated probably on a daily basis that so-and-so ordered a procedure, right? And of course, where we are, you don't order a procedure, you order a consult. We're happy to see any patient, inpatient or outpatient. We'll do our consult, we'll discuss. But we are often seen, right, as not the person with the catheter, the person with the needle, person with the ablation probe, right, the microwave probe, whatever it may be. And yes, we do have those tools, but we also have, I think, very robust training, right, in so many aspects of IR, specifically interventional oncology. And once we get in front of that patient, I think many times
close the deal.
We're attractive to them. Yeah. And again, not in a, I tell patients all the time, like, hey, I'm not here to sell you a car, right? I often want my patients to not decide right then. I actually say to them, I really want you to go home and think about this. I want you to call me. Now sometimes I realize things are more urgent, or they really want something done right away. In my other aspect of what I do, a lot of prostate embo, and I often tell patients, look, go home, think about this. I want you to then call me in a day or two. Now, if they're catheter dependent and they want the catheter out yesterday and they're going to embolize more urgently, sure, they don't want to go home and think about it. But same thing with the oncology. We don't want them to spend months, right? If they want to get multiple opinions, that's okay. I do fear, I've seen this happen. I'm sure you have as well. You have patients that sometimes go to 10 or 12 different opinions. They get paralyzed by indecision, but then months go by, right? So from an oncologic perspective, that could be a problem.
I think, we're also in a new day and age where information is much easier to get now. So I haven't
for good
seen
or bad.
It exactly affect yet, but I think with ChatGPT and things, people can really get some high quality info rather than going on, Dr. Google or WebMD, right? I mean, you can get some pretty focused info that is more or less accurate.
And, there's a lot of IR practices, though, that have also, I don't want to say got ahead of it, but that are, building more robust sort of online presence, right? Yeah. And that's important. Yeah. I mean, our patients, rightfully so, they're savvy. They know how to do their research and practices that are sort of patient forward and patient facing and trying to get as much information out there. I think some of them are benefiting from that as well.
Totally. I agree. Going back to microwave, and you mentioned you like a small number of lesions. You're not trying to go and do, 10 spots in the same session. What are other characteristics that make you lean towards? And then what are characteristics that make you lean against microwave?
Sure. If I have a lesion, 1, 2, maybe 3 lesions, but typically 1 or 2 lesions, and they're small, right? Maybe 2 centimeters up to 3 centimeters. And a location I think is safe, right? A perfect lesion is maybe a couple of centimeters deep to the capsule, something that I can get to relatively easily. And again, I have to think to myself, look, if there's 3 lesions in one segment, okay, then maybe I need to think something about Y90, right? But if there's 1 or 2 lesions in 2 different segments, I think that I can ablate it well in a small lesion and not sort of touch, potentially injure, treat too much additional parenchyma. I think you mentioned before, look, microwave is fast. I think the probes are sleeker than they once were. I feel like I'm much more comfortable now than I was even 10 years ago with the ablation zone that I'm getting. Sure, you can do multiphasic imaging, get a CT as you're working. The device I'm using now, they have thermocoupling, and I think I have a more trust in the equipment than I did, again, 5-10 years ago. I find it really easy to use. If I'm going to do an ablation, of course, you often can have the vendor there and supporting, and that's fantastic. Industry partners can be super valuable with that. You might have varying CT techs or other types of techs in the room, but the interface on the system I'm using now, it's very easy to use. I think that even a tech that's in the room that hasn't used it before, literally walk through, it's touch control. It's fast, it's easy. But again, it's not a race, right? So yes, it's efficient, yes, it's easy, but in my experience, it's working well, right? I'm having good outcomes. I'm getting the ablation zones that I want. again, you undertreat with ablation, that can be a real problem because you're basically ablating off. And if you undertreat, you might ablate the center, and it's almost like now you've left the periphery, you left the rind of the orange, and now you have to get even bigger to treat it. We do not want to do that, right? I don't care where we are in the body. We don't want to do that, and we haven't helped the patient then. One probe now, you can get typically a larger ablation zone than you would have before. I'm typically using the Varian system. They have a newer system out. It's a more spherical ablation than certainly we were used to seeing years ago. And you could put 2 probes in, you could put 1 probe in. You can, if you have 2 probes, you can do 2 lesions at once and keep the probes separate, or you can link them, sort of couple them, and a lot of options. And it's all on a computer screen, touch screen in the system. And it I don't know, I find it incably easier to use and understand.
That. I mean, so the microwave system that I was using in my prior practice it was just a legacy that they had, due to whatever contract. And there was this thing called Amica, and worked very well, but the font looked like it was like a third grader, right? And the packaging was
I've used that myself. Yep.
But it worked. Like I nothing against them, but it was a very much like I needed the rep there. I didn't know how to work that system. I do think that system's probably pretty old, but heck, I could get some big ablation zones when I wanted to, right? Like some up the wattage 100, whatever. But I always have to look at a guide, a chart, and I think the zones were not as predictable, but they worked. And fortunately, I don't think I ever had anything, undertreated for the ones that I did. But let's talk about how that technology has improved. I mean, there's all this pre-procedural planning, fusion software. Talk about us. You're talking about Varian, and how what kind of stuff do you have now that I didn't have using Amica?
Yeah. So and I happen to use historically, Varian was Endocare Healthtronics before, and I knew of them really from my cryo practice, and I had used their cryo technology, and I was really satisfied with the service they provided me, and sometimes maybe that sounds naive to say, but I valued that tremendously. So when this was evolving, and again, just sort of full disclosure, I had the opportunity to have a little bit of some conversations with some folks and engineers and stuff back in the day as they were developing this, and I was just really struck by. They really seemed sort of committed to try to make a better ablation device, something that was going to, number one, help patients, but was going to be sort of clinically driven, clinician friendly, if that makes sense. I know we joke about the font on some of these other devices and looking at the cookbook and figuring it out. I mean, everything is now, it's on the box. It's on not a box, it's the device, and it's sort of a touch system. And,
That's nice.
And you basically tell it where you are in the body. You can choose, I think you can choose liver, lung, kidney, and then I think there's another, but basically you choose liver and you say 1 probe or 2, and you're going to put in basically the size of ablation zone you need, and it will make suggestions about time and wattage. And the probe itself, I find it to be easier to place than some of the older generations probes. I think it's a little sleeker. I mean, the tip is certainly sharp. It gets in the liver sort of nice and easily, but I also don't feel like it's so sharp that I've lost control, right? You don't want to go in too deep, of course. You can sort of stick it, so to speak. I think it's sort of their microwave technology will hold it in place. If you're not sure, you want to do a scan.
Cryo.
And see.
I know cryo sticking.
It's not cryo. I think it's a certain amount of microwave energy they're using to sort of hold it in position. I believe. I'm not an engineer, but I think that's how
cool.
That's how it works.
Cool
but
I agree, because you're moving
cool.
in and out of the gantry. You're worried if you're going for a superficial liver lesion. It's like, oh no, if it moves a little.
Yep. Yeah. Absolutely.
It's a little scary,
absolutely. And then if I'm using 1 probe, as it's ablating, there's a couple like thermocouples built into the probe. I think it's 3, 4, 5 centimeters. It's sort of built back, and it'll tell you where we are Celsius temperature. And that to me is helpful to hopefully confirm that I'm getting temperatures that I expect as we're moving out, depending on how big of an ablation zone I want. There's an option to put in another sensor, another probe that you can put in at where the expected edge of where you want to treat up to, and you could thermocouple it that way too. I honestly typically haven't done that.
You can customize the length or something?
Yeah, well, but you could basically put a small probe, parallel or a couple centimeters
I see what you're saying.
Outside, right? To be extra sure that, okay, well, what's the temperature? I mean, ultimately with microwave, what's the temperature? What Celsius temperature am I getting to, right? If I think I want to get up to 50 degrees Celsius or certainly hot or warmer than that, and I'm not there yet, okay, well, I need to treat a little bit more. Now, again, I have had the experience that I've been really happy with the ablation zones I've been able to achieve, truthfully with other vendors before, but really certainly now, in a way though with more power, right, with a single probe, and again, it's definitely more spherical, right? So when we had that more elliptical thing, you'd often, you put the probe in deeper, and that's okay. You'd burn, and then you'd pull back and you burn a bit more. And that's all right. I mean, it's still pretty quick, but this makes it typically even faster. Again, you could track ablate like you can with other microwave technologies, which I think is great as well. Yes, there's this guidance, there's sort of guidance software that you could use ahead of time, analyze the scan and use their equipment to sort of give a sense of probe position, again, how much you're likely going to ablate for and what wattage, although that'll be confirmed as you're working, angles to take that maybe you hadn't thought of. I think most of us were stuck to our ways over years. We joked about how we trained in fellowship, but be open to some of this new technology. Sometimes have been a little slow, I think, sometimes to open my eyes to this. We happen to have a lot of Siemens equipment in our institution as well. So, one can actually link potentially this microwave system to their CAT scanner. And then, if you're one that uses the lasers that are built in the CT to guide some people, I actually love that for when I'm doing biopsies. But with ablation, you can do that as well. These systems could potentially talk to each other. I don't know that that's something everyone's doing regularly now, but I think in hopefully the very near future, if somebody happens to be using this ablation software and equipment and has certain Siemens CT technology, again, we don't want to make it too easy. We have a skill. We've learned to be very skilled, right, to think three-dimensionally and to do this.
Don't make it too easy. So,
but it's great. I mean, again, we are there to number one, number one, not hurt the patient, right? Number two, help the patient, hopefully in parallel, and then hopefully to do so efficiently, right? I mean, the more efficient we are from a pure IR patient-centered way is we can help more people.
Yeah.
Right. We can get more procedures done. We can take better care of more people. And again, it's not a race, but efficiency is valuable.
Yeah, totally. These kind of extra features you mentioned, is that just like specifically to Varian and things like that? Is that just available on the systems? Do you have to buy more packages? Do you have to sometimes it gets a little crazy, right? It's like, okay, well, I got this, and then now I do this and then that. I'm not sure if you know the answer. I don't
think I have all the answers. However, I'll just make them. No, I'm not going to make them up. I know that with everybody that's using the equipment can certainly, they have access to the initial pre-planning software, right? You can look at the scan, look at your CT, MR, whatever it may be, and start to sort of play a bit, shall we say, ahead of time to say, okay, what angle do I want to take? What may be the best way to cover this, right? And do I think I need one probe or two probes? And what's that going to look like when I have a synergistic ablation zone? The fusion to the CAT scan, I think, is more unique. I think that's a bit of a separate package. And I think, and again, I could be wrong, but I think in 2025, not every CAT scan is going to necessarily have that technology. But I would say that if somebody is using the equipment already, Varian microwave system, or they're thinking about using it and they have Siemens equipment, I mean, the beauty of this, of the integration is that, the reps, the team there at Siemens, at Varian, are going to be able to tell you, and they'll be able to say, look, here's what you have access to. Is it even possible? Or it might be that, hey, the next time your CT is upgraded, that might be something we can do. So I think the fusion type of using the lasers to overlap is not necessarily something that everybody has access to and may have to invest in a bit, but not so much with the pre-stuff, right? With the ablation planning information. And again, I was a little skeptical of that initially, is that I've done hundreds of ablations, maybe more than hundreds, right? And I can think through this and I can think 3D, and I love trying to think that way. But let's use technology, right? Let's use technology along with hopefully my skill set to, again, do even better.
Jason, I'm going to come up with some other kind of situations that I found myself in doing microwave ablation. I wanted to pick your brain. Frequently I'll have a CT that has maybe a single phase study, maybe not a non-contrast phase, or an MRI. I'll have no ultrasound of the patient. I see them in clinic and I want to do microwave. Do you tend to try to see, is this visible with non-contrast imaging? Is it visible with ultrasound before taking them to microwave? And then is there anything with this pre-planning software that you are mentioning with Varian and maybe some other vendors? Does that happen? I get a little confused, and as you know, it can be hard adding another study, then you're delaying care. You just want to get treated. Yeah,
no, great question. I think look, in a perfect world, we have an ultrasound, a PET CT, a multiphasic CT, and MR, and everyone, our DR colleagues would love that because that's probably a lot of our views anyway. But the reality is, the one thing you want is probably the thing you don't have, right? That's how life will go, and you don't have it. So to me, it's a little bit of a case-by-case basis, right? If I'm particularly worried about if I'm going to be able to see this, then yeah, I might get a multiphasic scan beforehand, right? Because the last thing I want to do is to sort of not promise something, but to say that I think I could do something and really in my heart be not sure about it, right? That being said, in my experience, like a lot of my patients ended up having a PET CT and an MR, right? So I realize some PET CTs now are going to be done with contrast, but a lot of them aren't, right? So if it's a non-con sort of a poorer quality, shall we say, non-con CT, and I can see it on that, then I'm happy. That being said, there's some other tricks, right? I mean, look, sometimes if I'm doing this typically with CT guidance, but I do have ultrasound in the room. So I always have both. So I'm going to look with both. Sometimes I'll do quick multiphasic CT with the patient on the table, right? And that'll help me to see where this is. And you can use software, at least on our CT equipment, we can triangulate on that, right? So we can draw sort of a cursor, almost put like a little red dot on the whatever phase of imaging we want, but it'll track that.
Ooh.
It'll track that area for us.
Oh, I didn't have that. That's pretty cool.
Then it depends on the level of sedation, right? So if you have a patient that you're doing this with deep sedation, so let's say monitored anesthesia care or propofol, where you can't control respiration, basically, you might have a little bit of a harder time. You have to just be careful as you're tracking that to make sure it's where we think we are. But the technology is phenomenal now on all sorts of different vendor CTs now to track. If you're a general anesthesia provider, shall we say, likes that, then you could also, if you suspend respirations for the CT when you're getting that phase of imaging, and then you're suspending respiration when you're moving the probe, that localization can even be more powerful, right? Because I think we're even more certain. That being said, I've been very impressed even when a patient is awake, when I've used that sort of triangulation little box, even if I'm using it for a difficult biopsy, same concept. It's incredible, at least for me, I'd be lying to tell you exactly what type of Siemens CT scanner we have. Sure. I'm not totally sure the name of it right now, it's the Slice 2000. It's phenomenal that you have that as a tool. And again, some of us might be sometimes a little more old school and say, look, I can do it. I can triangulate in my mind. I can use landmarks. But if you have the technology available, whether it's with our ablation system or with the CT we have in the room, and let alone can you then link your ultrasound and your CT together, right? All these things are evolving. Again, if it helps us to better serve the patient, let's be open to it. Let's learn about it.
Totally. And one other thing I was thinking about is, do you do any kind of like intraarterial epiidol to stain the tumor before? But with all these technologies, you probably don't need to.
Yeah, usually not. One of the things, again, this is now going back to training again. So a while ago, more than 15 years ago, 17 years ago, some of that RF ablation literature. Now, this was more HCC, admittedly,
sure.
So I'm sort of crossing.
Exactly.
But would say, look, there's some data with 3 to 5 centimeter tumors. If you're going to ablate, to say, look, there might be some benefits to doing embolization than ablating, right? Perhaps, and again, that was a little bit earlier with RF, but are we going to have less heat sink, right? Heat loss. Are we going to be able to see things better, right? So I think it's something that we can have in our toolbox. Sure, you can certainly do that at times. In my practice, the patients I'm seeing, the patients that I'm ablating, have I done an embolization first before? Sure, I've definitely done that at times, but I'd say it's a small percentage. It's certainly not the majority of patients.
And, it's pretty cool you mentioned how you can just select where you are, tell the size of the tumor in it, because again, with my prior system, it would be this chart. And then I would pick like, okay, maybe not 5 minutes, maybe not 10 minutes. Let me do 7 minutes, and it's going to be in between. So it seems like with Varian, and it actually pretty much tells you what to do, and it has obviously so much data and then things to kind of come up with these more predictable volumes.
Sure. Yeah, I mean, tells us what to do. It has suggestions, things like that. That being said, right, we have our own expertise, right, as well-trained interventional radiologists. So don't lose sight of that either, right? We're our own experts as well, and always pay attention during the ablation. If there's something that you're a little surprised by, let's take a step back and think about it, look at it. The thermocouples that are there, again, give me a sort of a number, right, a temperature number as we're moving away, and then you think about that three-dimensionally, right? You can apply that. But if you're ever uncertain, and we think that we need to maybe move that probe, if you're going to use one probe and touch up another spot, right, do it, right? If you're uncertain, you generally need to ablate, a little bit more, a little bit bigger margin. But sure, if you're using the pre-ablation software, you can experiment with that a little bit, like on a laptop or on the computer, to say, okay, if
can learn a little from it.
What do we think we're going to get, right? And again, I understand these things aren't sort of guaranteed, right? Every patient's a little bit different. Everybody's body's a little different, right? But then you watch, you take what you learned with the pre-ablation software, and then you apply it real life in that patient. And if you're a little surprised to say, wow, it's actually getting hotter at the 4 or 5 centimeter thermocouple than I was expecting, or it's not as hot, okay, then we maybe need to ablate a little longer or a little bit less. And in a very worst case scenario, again, if you're not sure at the end, definitely okay to do a lot of people do this all the time, multiphasic scan at the end to confirm, right? Make sure that we got what we wanted, what we planned. And I think many people, like a lot of us, do that now routinely. And that's great. Again, the goal is to make sure that we're optimally treating the patient. And if we get sort of surprised, shall we say, every once in a while, say, wow, I need to ablate this spot a little more. Great. We figured it out during the procedure. We take care of it. 10 more extra minutes of work. Great. We've helped the patient.
Anything about, with these newer systems, cost, are these probes cheaper than before? Do you know anything around that aspect of it?
I don't know a ton about that. I don't think there's been a tremendous difference on our end. Now, that being said, I realize that each institution may have different negotiations and things like that and how that works. So, but I would say, look, I mean, these are important things to know, right? So if one is in the market for a new system or wanting to learn about just other options, including Varian, reach out, right? And talk to the rep, and they'll sometimes some of this has already been predetermined. If you're part of a large health system, for example, and it's already in another campus, shall we say, using my NYU experience as an example, sometimes there's things approved for use. As I'm thinking about value analysis, do I have to get something in? And it's actually already in the system. We just don't have it on our campus. And
sure,
yes, we want to understand about cost. Although, again, we want to be cost effective. Don't get me wrong. We, if we can do something that costs $2,000 versus $10,000 and it works just as well, we should be thoughtful about that and careful. But we also want to make sure that we're using technology devices that in our hands are doing the best for the patient.
Absolutely. The other question that I had about microwave specifically was what's kind of what have you seen that's on the horizon? Like what else is in the future of it that you're seeing? Maybe with Varian or other systems that you've used. Is there like more AI? Is there more? I mean, obviously the zones are becoming more predictable. That's for sure.
Sure. I think there's no doubt, right, that there's going to be, look, we want as much real time, like legit real time, like in the second feedback as to, despite, the best, this amazing technology that now exists, we always want to do better. Right. So we want to be 100% certain that we are doing the optimal ablation zone, because a too big ablation zone is not good either. Right. That we're getting the optimal ablation zone. And hey, could we reshape the ablation zone as we're working? Is it possible to have the same probe do something spherical versus something different based on what we need? Right. Wouldn't that be cool? Is it possible, again, to, whether it's through AI, through some of this linkage between perhaps the CT system, the ultrasound, the machine itself, the ablation machine, and to be very confident, right? Like to be able to come out and tell the patient that we're not just sort of confident with our technical success, that, down the road, hopefully with more data, more research studies, and maybe AI or other fusion, software that we, yes, are technically very happy, but now we have more robust data and experience to say that we're even more confident than we were, again, 5-10 years ago, that now our chances for clinical improvement, right, are even better. The other thing I joked about it, and it's really nothing funny, I realize about chasing the abscopal effect and sort of the holy grail of being able to, ablate or target a tumor and have response other places. I mean, that's something that certainly I don't think any of us should ever be promising a patient. Totally. If the patient asks about it, we should understand we should understand what it is and be honest with our patients. But yeah, I mean, look, I hope, I pray that years down the road, that's something that we're going to really know more about and figure it out, right? But that's why we need, IRs around the world, around the country, whether they're in academic, powerhouse, shall we say, research institutions, or sometimes in smaller but equally valuable community hospitals doing great work, or anywhere in between, to be able to be involved in sometimes, whether it's sharing data or sharing experience or having expertise, right? Hopefully it's going to elevate all of us, right?
Totally. The other thing that came to my mind is about the sunsetting of New Wave. Any kind of comments on that? I mean, it was a good system. How does New Wave compare to what you're using now, Varian? And why would a company get rid of a complete system?
Yeah, it's a bit head scratching, right? Some of how that has evolved, how this has evolved over a relatively short period of time, right? And for example, new wave users that again, there's a lot of great devices out there, and new wave had it still probably does, right, have a lot of fans, shall we say, and satisfied users, and to have a system seemingly disappear, shall we say, right, where you wonder initially, well, why didn't another vendor want to take it over, buy it, things like that. And I realize some of these things are probably
they're probably over our head.
A little bit over. Believe it or not, even over your head. Definitely over my head, but yours.
Over my head. But I thought maybe this is interesting, right? It's just like, okay, it
is fascinating, right? And now again, if one system is not available, again, other vendors benefit from that, presumably, but it also could be if a practice was a new wave practice and isn't pivoting or hasn't been able to pivot or may need to pivot, they may, we don't want to hurt a patient, right? You don't want to hurt our ability to help a patient. It is definitely a bit head scratching, right? And again, I'm sure there's details that I don't know about. I'll tell you, I had been using this, the Varian Tailblade system really since it was, on the market and able to be used over the last year, a little bit more. I've used New Wave before. I'm certainly happy with it. I just, really had been excited about this system coming out a lot of because I was really happy with the customer service I got through Endocare Healthtronic, which became joined Siemens over the years. Just as I realized there's tons of New Wave users and users of other technology over the years that appreciated their clinical outcomes and appreciated the customer service. So, I can talk about my experience. Obviously, I've been super happy with Varian, but yeah, it is a little puzzling, a little head scratching. It's a little scary in a way, right? But there are some large institutions do a ton of ablation, and that would use New Wave or any other vendor many, many times a day. And if all of a sudden you don't have access to that and you have to pivot, there will be a learning curve, right, for your staff, for you as you switch. So yeah, you hope there'll be some sort of post-mortem, shall we say, and then a way for us to learn as a specialty as to sort of what happened and how we can navigate those sorts of things, right? There was a lot of shock.
I know some practices, and then again, like you said, does it hurt a patient, or maybe the access gets limited? Some hospitals don't want to buy a new machine. They're just like, okay, we'll just, and it could just be, it's just there's a whole different topic, right, about that. But I was interested just to see, that was a big news, as of 1 year ago, and continues. So you mentioned customer support. I think that's huge. I think one thing, and I know this episode is sponsored by Varian. Thank you so much. And I think their team is really good. They've got a leadership profile of a lot of good amazing IRs, and I don't think
absolutely
many companies have that. And I have to give mad kudos to that, because I think, and the Teresas, the Franks, those are great people to have on your leadership, and it's a model for other companies to have.
Yeah, absolutely. Look, highest level leadership is so core and central to that. And shall we say, some of the staff members, their workforce that are maybe we'd say more in the trenches on the ground doing ablations with us at times or helping to support cases. I've been really, really happy and sometimes really surprised, truthfully, about the level and quality of service. Now, again, I realize that other vendors are also awesome, but early on when I came to what was Winthrop and now NYU Long Island, a couple of cryos had been done, and we had Endocare, and I've used it ever since, and I've been super happy. And I'm not going to throw this guy's name out there, I don't want to embarrass him, but there's a rep who's now doing other work still within that same system within Varian, but his really willingness to help me build and have support and get information I needed, but what I think was in a very ethical way. I remember that, right? And other companies have had similar experiences with the embolization space or, biopsy space. Again, I don't care what it is, big procedure, small, these are important things. This is how we help patients. And again, if you feel like you're having really good customer service and you're not somehow servicing the patient with technical outcomes, that's a problem, right? But if you're getting great customer service and you're seeing that you're hopefully doing great work for your patients, to me, that's a win-win. That's where I see it in my practice at the moment. Again, others may, I realize, disagree or maybe not have experience with this, with Varian versus other vendors. But for me, it's been awesome.
Totally. Well, there's so much more we can talk about, Jason. It's been awesome.
Next time.
I know. Well, like I said, this is a multi-part series. We're going to talk a lot more about just things, but really enjoyed having you on. Like I said, I was a really big Y90, Riyadh Salem disciple. And then I was doing some more microwave. And like you said, it's faster, even with my older system, relatively predictable and very effective. And I think for other people who are, maybe shying away, to really explore. And with this is so great. Like a touch screen, gives me so much more info than just kind of guessing. I am definitely, excited to be, using Varian at my new job, actually. So look forward to learning more and having you back on. I mean, anything else, for our listeners that you want to kind of give parting words of wisdom before we end our episode today?
No, absolutely. I appreciate being back. It's a pleasure as always. And just, again, healthy partnerships with these newer devices that are out, and learn, right? Research, again, episodes like this and other BackTable, educational things that are out there. Check the websites of these different vendors, watch their educational and, shall we say, promotional material, but use it to learn, to then help yourself to interact with these different vendors to figure out what's best for your practice. There's no doubt. I really think microwave technology now in 2025, it's just incredible how things have evolved again in 10, 15 years. So
yeah,
happy to talk about it. Happy to be here.
Absolutely. I'm happy you're alive too. From
yeah, always a plus.
Definitely listen to Jason's episode about his experience with PVT, and it's a really great episode. So thank you so much. You guys have any questions for us or anything, just shoot us a message, shoot Dr. Hoffman a message. And let's wrap up. Thank you so much.
Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabeen Dhand,
and Aaron Fritz. Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.